Hello and welcome back to What the Health. I'm Julie Rovner, Chief Washington Correspondent for KFF Health News, and I'm joined by some of the best and smartest health reporters in Washington. We're taping this week on Thursday, April 3rd at 10 a.m. As always, news happens fast and things might have changed by the time you hear this. So here we go. Today, we are joined via video conference by Sarah Carlin-Smith of The Pink Sheet.
Hi, Julie.
Lauren Weber of The Washington Post.
Hello, hello.
And we welcome back to the podcast Rachel Korzang, now at Bloomberg News.
Hi, everyone.
Later in this episode, we'll have my interview with my colleague Julie Appleby, who reported and wrote the latest KFF Health News Bill of the Month about yet another very expensive colonoscopy. But first, this week's news. We're going to start this week, as usual, with the latest changes to the Department of Health and Human Services from the Trump administration. But before we dive in, I want to exercise my host prerogative to make a personal observation for those who think that what's happening here is, quote, politics as usual. I am now a month into my 40th year of covering health policy in Washington and HHS in particular. When I began, Ronald Reagan was still president. So I've been through Democratic and Republican administrations and Democratic and Republican-controlled Congresses and all the changeovers that have resulted therefrom. And obviously, the HHS I cover today is far different from the one I covered in 1986. But I can safely say I have never seen such a swift and sweeping dismantling of the structure that oversees the U.S. health system as we've witnessed these past 60 days. Agencies and programs that were the result of years of expert consultations and political compromises have been summarily eliminated, and health and science professionals with thousands of years of combined experience cut loose via middle-of-the-night form emails. To call the scope and speed of the changes breathtaking is an understatement, and while I won't take any more personal time here, if you want to hear me expand further on just how different this all really is, I'm on this week's episode of my friend Dan Korenstein's Trade-Offs podcast, which you should all be listening to anyway. All right, that said, now let's dive in. I suppose it was inevitable that we would see the results of last week's announced reorganization of HHS on April Fool's Day. Let's start with who was let go. While the announcement last week suggested it would mostly be redundancies in things like IT and HR and procurement, there were a bunch of longtime leaders included in this purge, right?
Yeah, at FDA, there were some of the most senior scientists, like their Office of New Drug Directors, their Chief Medical Officer, almost everybody who works on policy, legislative affairs, entire communications offices, external affairs. And even in the case where they are laying off people whose job titles might sound extraneous or not as important to the health of people in the U.S. I think you can sort of debate that, but they did it in such a way that they laid off so many people in those departments that the people they said we are protecting because we do at least understand these jobs are important cannot actually fully do their jobs. So scientists are not able to access the supplies they need. It's not even clear how people at FDA are going to get paid and do their timesheets and attract time given how many people they laid off. And it also just seems like there's been a ton of, again, to the extent they were trying to protect certain positions that they deemed more critical to U.S. health and well-being, like medical reviewers or inspectors. They didn't quite understand who actually is critical to doing that work, because it's not just somebody who has like inspector in the title. Vanity Fair had a great piece about this man who really has saved people in the U.S. from going blind by helping inspectors catch sterility issues and eye drops. And they walk through very clearly how people like him do not have a title of inspector, but are absolutely needed to ensure we have drugs that are safe for people in the U.S. So probably not surprising to people who've tracked the administration so far, but it's been a lot of the move fast, break things, and then realize on the back end that they maybe broke things they didn't necessarily mean to, or don't actually care as much about whether it's broken.
Lauren.
They got rid of the head veterinarian on the bird flu response. That would seem to be a thing that is surprising. I spoke to a congressman yesterday who said that seems very dumb. It's not just that. They also eliminated entire swaths of the CDC, small agencies that maybe a lot of people have no idea alphabetically what they do, but are pivotal in preventing injury deaths and in really the preventative and chronic disease care that RFK has said is really vital to getting America back on track. When we talk about dollars and cents saved in healthcare, a lot of that is in chronic disease and in preventative care. And to see some of these places get hit so broadly is quite shocking, considering the end goal is allegedly to save money.
There are also a lot of things that seem sort of at odds with Trump's own agenda. David Kessler, the former FDA commissioner, was on TV last night talking about how the people who answer the phones when a doctor wants to get an emergency use authorization for a drug that's not yet approved, that's something that's been a very big deal for Donald Trump. The people who answer the phones got fired. So when a doctor has a patient who who nothing else will work and they need an experimental drug and they're supposed to be able to call FDA, and I think there are rules about how fast FDA is supposed to respond, but now there's nobody to actually answer the phone and take those requests.
Yeah, I think the list of things that don't seem to align is very long. You know, one thing I was talking to somebody about yesterday, they said, well, pretty much everybody who deals with tracking pesticides and foods and food safety at the FDA in regards to pesticides was let go, and making our food system healthier and safer and concerns about pesticides has actually been a big focus of RFK. Similarly, Martin McCary talked a lot in his opening speech to FDA employees yesterday about obesity, and they are basically gutting offices that work on pediatrics, minority health. They've laid off lots of people in their tobacco division at FDA, and FDA's tobacco division actually is not funded at all by taxpayer funding. So, you know, I have a hard time understanding how anybody besides the tobacco industry really benefits from this loss. And as Lauren said, it's like every health agency, you can kind of find examples of that. You know, they say, you know, America is not healthy, but they're cutting these top researchers that have found incredible advances in Parkinson's and some of the chronic diseases he's most cared about.
They also, I mean, there are some big names who were let go. I mean, the Peter Marks firing at FDA happened last week after we taped, so we haven't even talked about that. Somebody tell us who Peter Marks is and why everybody's all freaked out about that.
Well, Peter Marks was head of the division of biologics and the top regulator of vaccines and complicated injectable medicines, like insulin products too, fell under his purview. And I think we saw markets react in a panic on Monday. You know, the shares of vaccine makers like Moderna were falling, and we saw companies cell and gene therapies that Peter Marks has been, really involved in regulating and championing through some of those processes. They were kind of freaked out because it just creates uncertainty as to kind of what the new philosophy toward these medicines will be. And the Trump administration, we've seen, especially on the Marks, being pushed out. I think they've tried to highlight some of his more controversial actions in the past. We saw White House advisor Callie Means was personally attacking Marks for some conflicts he had with vaccine regulators during debate over the COVID booster approvals and just his decisions to overrule recommendations by FDA experts on some innovative medications that some people disagreed with. But the perspective from former officials has been that, like Peter Marks or not, the idea that scientific expertise is being purged in this way is concerning. And it wasn't just Peter Marks. There's another regulator at the Office of New Drugs, Peter Stein, who was pushed out. We have Anthony Fauci's successor at NIH was pushed out, Gene Marazzo, as well as a couple other heads of scientific research institutes at NIH. And
Anthony Fauci's wife was pushed out.
Yeah,
Who's a bioethicist, the head of the Office of Bioethics at NIH.
Truly. And I think we had heard that some of these more politically sensitive center leader positions would be at risk. We've heard this for a very long time, but it seems like they took advantage of the chaos to implement some of these high-level cuts to people that they may have disagreed with. That people will be filling those positions. I don't know that there's a cost-saving argument there, but it certainly seems like they were trying to push out senior leaders with a lot of experience.
It also feels like the way that people were let go seems, to put it bluntly, purposely cruel. Like sending out RIF notices at 5 a.m. and then having people find out they've been let go when they stand in long lines only to find out that their IDs no longer work. Or CMS employees being directed to contact a person who died last year. Is there a strategy here? Lauren, you wanted to add something.
I wrote a story on the CMS employees being told to contact someone who was dead. And I mean, I spoke to one of this woman, Anita Pinder's former colleagues, who said she was just heartbroken. She said CMS employees who got that email had gone to this woman's funeral. And what a gut punch. She said, look, this person who was talking to me was a former CMS employee, said, look, there always is a way to reorganize. It's not that there isn't waste or ability to consolidate or streamline in the federal government. She's like, that's not my problem. My problem, this woman told me, was that it was done in such a way that you really can't take that back. People getting a dead woman's name as their point of contact to contest their firings is something that is difficult to take back.
I guess my question is this just sloppy, or are they actually trying to be cruel in this? Because it certainly feels like they're trying to be cruel.
I think it's possible. It's both, a combination, one or the other. Again, it seems like the people who are doing this are not expert, right? They didn't actually take the time to assess HHS and all of what the agency does to understand what people do for the government beyond just looking at their job titles. And so some of it may be intentional cruelty, and some of it just may be really just rushing and not understanding the process. I mean, there were other notices at FDA that were signed by somebody that no longer worked there. People's performance scores were wrong. The sense is they didn't follow the normal process of when you do a RIF, you have to give. There's certain people that get preferences and who stays and who goes, and whether it's veteran status, disability, all those things. And I think some of that will probably result in legal challenges down the line, including they got rid of certain offices or everybody in them that were mandated by Congress. So some of it's probably sloppy, but some of it is right. They don't really care how they treat people because there is a very clear message that comes from their rhetoric of kind of lack of respect for government bureaucracy.
And I know some of these senior leaders, they figured out that they can't just summarily fire them. So a number of them were offered transfers to the Indian Health Service in places like Alaska and Montana. And they were given, 36 hours to decide whether they would accept the transfer. And we're told that Secretary Kennedy is very concerned about Native populations and the Indian Health Service, which is short of workers in a lot of places. But this seemed to be insulting to both the people who were given these quote unquote transfers and to the Indian Health Service, because it wasn't sending the Indian Health Service what it actually needs, which are practitioners, doctors and nurses and laboratory workers. It was sending research analysts and bench scientists and people whose qualifications do not match what the IHS needs.
Right. They wanted to send, I think, the FDA's tobacco head to the IHS to do, I think, medical care. So it enraged people in the IHS.
Yeah, I don't think the Native population was really thrilled about this either. Lauren, you want to add something?
Yeah, I would just say that this is a playbook the Trump administration has executed in other government agencies. Members of the FBI, top leaders of the FBI were reassigned to, child sex trafficking crimes or far away distant lands in the hopes of getting them to resign. So, I think we are seeing it play out at HHS, but it certainly is a tactic they've used in other federal agencies to, quote unquote, drain the swamp.
Right. And in the first Trump administration, they did move some offices out of Washington to the middle of the country, if you will. And most people obviously didn't go. And now there's a lot of expertise that, again, that we lost. I think that really can't be overstated, is how much expertise is being pushed out the door right now in terms of things that, as I said, this administration says that it wants to do or get accomplished. Meanwhile, Secretary Kennedy has been invited, or should I say summoned, to come testify next week before the Senate Health Committee at the behest of Republican Chairman Bill Cassidy, Democratic Ranking Member Bernie Sanders. So far, Congress has mostly just been kind of sitting back and watching all of this happen. Is there any indication that that's about to change?
I think Democrats are pushing a little bit harder, but I'm not sure they have enough power or have enough, again, momentum yet to actually do what they can with their power. I'm interested to see how Cassidy handles this hearing going forward, because his statement the day of the big reduction in force seemed to suggest that the media was maybe unfairly reporting on it, and that Kennedy may have another side to the story to share to justify it. And it didn't sound like somebody that was necessarily going to go particularly hard at RFK. It seemed like somebody who wanted to give him a chance to justify his moves. But we'll see what happens. I think Cassidy has been, despite RFK walking back a lot of his promises he made to Cassidy around vaccines and so forth, Cassidy has not been that willing to go hard on him so far.
Yeah, the other thing we've seen is that most of the big health groups that you would expect to be out on the front lines, hair on fire, have actually been keeping their heads down through most of these huge changes. But that seems to be maybe changing a little bit too. I mean, this is a pretty dramatic change to get not a huge response from. I've seen way lesser changes get way bigger responses.
Yeah, I think I spend a lot of time thinking about like what is going to be the last straw for some of these organizations. And I think we saw some more effective organizing from like the medical device industry when actual medical device reviewers were laid off. And I think they went public pretty quickly and those people were rehired. But I think it's important to remember that some of these larger trade organizations and these companies are looking at a broader picture here. And there are all these different pieces of the puzzle. And certainly, I think we've seen some trade groups that represent like pharmaceutical companies criticize some of the cutbacks at HHS, but also for now, were spared in a tariff announcement this week. And so I think they're trying to walk this tightrope where they have to figure out how to get the wins that they think they need and take losses in other places and hope it kind of all evens out for them. So I think they're in a tough situation, and I think there's much more concern behind the scenes than we're seeing spill out into the public. But I think at some point, maybe the line will be crossed, and I just don't think we've seen that quite yet.
Yeah, I think the dam is definitely starting to break a bit, though. I was shocked, what day was it? Tuesday, when all this happened, when finally late in the day, Farmer sent a statement, and it was more scathing than you might even expect. And I think it was the first time they've actually responded to anything I've asked them to respond to that the administration does. And they said that it's going to raise crucial questions about, the FDA's ability to fulfill its role. And so I think that is a big sign because, as Rachel mentioned, the medical device community was willing to stick their neck out there when they felt they were really harmed. Smaller trade associations have starting to push back. But the silence has really been notable, I think, by people outside who were hoping that these powerful industries that have sort of more connections to the Republican Party would use that leverage, and they sort of felt abandoned by them. So I think that is a significant crack to follow.
I feel like everybody's waiting for somebody else to stand up and see if they get their head chopped off. I agree. I mean, I'm hearing the concern too, but publicly, not so much. Well, moving to Capitol Hill, Congress is in this week. Well, they were in. We'll get to the House in a minute. But first, in the Senate, New Jersey's Cory Booker set a new record for holding the floor, which is saying something for a place where being long-winded is basically a prerequisite. 25 hours and 5 minutes, besting by almost an hour the 1957 filibuster against the Civil Rights Act by Strom Thurmond of South Carolina. Much of what Booker talked about during his more than a day on the Senate floor was health care. Is this still the issue that Democrats are hoping to ride to their political return?
I was going to say, I mean, if the massive Medicaid cuts that are forecasts come through, I do think that will be the midterm political return of Democrats. I mean, I think the writing is on the wall politically for Republicans if those do go through, which is why I think you're seeing a lot of Republican leaders start to say, oh, no, we don't want some of these Medicaid cuts like this. But I mean, to be determined how that actually plays out.
Rachel.
I was just going to say that Democrats are just trying to figure out something that will break through to people. They're just trying to throw spaghetti at the wall and see if there's, some strategy they can find to get through to people. And I think this, just given the viewership of Senator Booker's speech, seemed to break through in a way and felt like even though Democrats do have really limited levers of power in Washington right now, that at least somebody was doing something, and that's kind of the takeaway that I had from that speech. But I will say, I think Congressman Jake Auchincloss appeared after White House advisor Callie Means criticized the health scientific establishment and HHS was defending these cuts. And Congressman Auchincloss, I think, did have a more forceful tone in pushing back and just arguing for the scientific advances that have happened, and had some like camera-ready little tidbits about the new administration being run by like conspiracy theorists and podcast bros. And I think they're trying to figure out like how to push back and how to get through to people and what approaches are going to work. And I think that was just a new tactic that we saw break through.
Well, if the Democrats did want to make a statement about Medicaid, they could make a stand against President Trump's nominee to head the Medicaid program, as well as Medicare and the ACA, Dr. Mehmet Oz. That vote is scheduled in the Senate for today after we finish taping. But we're not really seeing that much pushback, are we, Lauren?
Not so far. I mean, I guess we'll see. We're taping before this happens. But I mean, Mehmet Oz really waltzed through his confirmation hearing process. I mean, it's rare that you see someone who will lead such a massive agency on healthcare mention the multiple daytime Emmys he's won, but I think that helped in his charming of legislators. I mean, his daytime bona fides were on high display. He was able to dodge multiple questions about what he would do about cuts to Medicaid, and even Democratic senators were inviting him to come to church. I mean, I would be surprised if we see some sort of big stand today.
He was super well prepped, which we said. We did a special after the hearing, which is of all of the Trump nominees, I think he was the best prepped of anybody I've seen. He was ready with tidbits from every single member of the committee. But I will say that, going back years, and as I said, 40 years, this is a position that one party or the other has frequently blocked, not for reasons that the nominee was not qualified, but because they wanted to make a point about something that was going on at the agency. And it kind of surprises me that we haven't seen that sort of thing. I mean, there were years where we did not have a Senate-approved head of Medicare and Medicaid. Sarah, as you pointed out, there were years when we didn't have a Senate-approved head of the FDA for the same reason. Had nothing to do with the nominee, had everything to do with the party that was out of power trying to use that as leverage to make a point. And we're just not even seeing the Democrats try that.
I mean, I guess we'll see this afternoon. You could be forecasting what's going to happen, Julie. But I think on top of him being well prepped, I mean, Oz does have a history in healthcare, is a very accomplished surgeon. But what is fascinating to me is that he's coming back to the Senate after a 2014 grilling by the Senate on his pushing of supplements and other things for, quote, fat blasting and, quote, weight loss products. And I mean, it's just the turnaround of daytime TV star to failed Senate candidate to potential administrator for CMS, which runs hundreds of millions Americans' health insurance, potentially at a very consequential period in which there are massive cuts to them, is really going to be something.
Yes, yet another eye-opening thing out of this administration. Well, over in the House, things are a little more confusing. On Tuesday, the usually unified Republicans rejected a rule, normally a party line vote, because Speaker Mike Johnson was using it to avoid a vote on a bill that would allow new parents to vote by proxy, basically granting them parental leave. I did not have this fight on my bingo card for this year. It's actually less a partisan fight than one between younger, read childbearing age, members of Congress, and older ones from both parties. I'm kind of surprised that this, of all things, is what stopped the House from doing business this week.
Yeah, I think that it is an interesting contrast here because House Republicans have, had this very pro-family rhetoric in the campaign, but they also have been so against remote work in any fashion. And members of Congress travel really far. There's a time in pregnancy when you can no longer fly on a plane. And so I think given Republicans' really, really slim majority in the House, it puts them in kind of a pickle, where they need these votes to keep the majority. But it kind of sits at the intersection of all these different forces at play. So I think, just a really weird political pickle that House Republicans have found themselves in this week.
Yeah, and of course, this was a member of the House Freedom Caucus, a Republican member of the House Freedom Caucus, who was pushing this, who got a majority of the House to sign her discharge petition, which is supposed to bring this bill to the floor. So we'll see how that one plays out. Obviously, with everything else that's going on, it's not the biggest story, but it sure is interesting. Well, the big non-health news of the week are the tariffs that President Trump announced in the Rose Garden Wednesday afternoon. There is a healthcare angle to this story. The tariffs reportedly include at least some drugs and drug ingredients that are manufactured overseas. This, again, feels like it's going to do exactly the opposite of what the president says he wants to do in terms of reducing drug prices, right?
I mean, yes, that would seem to be exactly how that is likely to go. I mean, even look at drugs we get from Canada. I mean, they're going to have tariffs on them. I mean, I think we have to wait and see exactly what happens. I mean, Trump has had a history of proposing these and then taking them back. Obviously, these are much more sweeping than the ones we've seen so far. So I think it the jury is out on how exactly this will play out over the next couple of weeks.
Right. And
so there's also the exception process, right? Is that
yeah, I mean, there's been, I think, a lot of confusion and lack of clarity around exactly what happened yesterday here. It seems like the drug industry did get some key exemptions, but people are trying to kind of clarify some of those, including like, do just apply to like finished product? Do ingredients that they need lower down in the supply chain get impacted? So I think it seems like pharma at least got like some amount of a win here and got like kind of some of the typical exemptions for medicines, but people are not confident in all of that and how it's going to play out. And I've seen sort of mixed reactions from analysts in the space. But yeah, I mean, it's just like other parts of the economy that people have talked about with tariffs. It's not entirely clear how like the average American consumer would actually benefit from these tariffs versus having to just pay more money for goods.
We are apparently going to tariff penguins from islands off the coast of Australia. That much we seem clear on this morning. Turning to abortion this week, as we mentioned last week, the Supreme Court heard a case out of South Carolina testing whether a state can kick Planned Parenthood not just out of the federal family planning program, Title X, but whether Planned Parenthood can be disallowed from providing Medicaid services as well. Now, Planned Parenthood gets way more money from Medicaid than it does from Title X, and neither program allows the use of federal funds to pay for abortion. I will say that again. Neither program allows the use of federal funds to pay for abortion. Interestingly, it seems the High Court might actually be leaning towards Planned Parenthood in this case, not because the conservative justices have any sympathy towards Planned Parenthood, but because the court has fairly recently made it clear that the provision of Medicaid law that says patients can choose any qualified provider actually means what it says. The patient can choose any qualified provider. At the same time, though, the Trump administration this week declined to distribute a big swath of that Title X funding. And you have to wonder whether even if Planned Parenthood wins this South Carolina case, what's going to be left of either Title X or the Medicaid program? Possibly a Pyrrhic victory coming here. It seems that this administration is just whacking things. And even if the court ultimately says you can't kick them out, there's going to be nothing for them to stay in.
The any like willing provider debate struck me as sort of most interesting here because that type of clause seems to be something you typically see like conservatives want to put into a government health program. They don't feel comfortable kind of restricting people and choices in that way around who they see. So that was one of the elements of this case. The other thing that I think is being watched is this argument that the state is making around like how you enforce disagreements, I guess, around how the Medicaid program is being operated. And that seems like it could have a lot of long-lasting impacts as well if people, depending on if the court weighs in on that and so forth, just what rights people have to contest problematic decisions made in state Medicaid programs.
Yeah, but this was for the first hour of the debate, the word abortion wasn't mentioned. The word Planned Parenthood wasn't mentioned. I mean, this was really about whether patients actually have a right to sue over not being able to get the kind of care that they want, which has been a long-standing fight in Medicaid. Back to, I think, pretty much the beginning of Medicaid. So we'll see how this one comes out. Well, turning to the states, and another case we have talked about, Texas wants to prosecute a New York doctor who was acting legally under New York law from prescribing abortion pills via telemedicine to a Texas patient. The latest is that the court clerk in Ulster County, New York, has refused to file a judgment for the $100,000 fine that Texas says the New York doctor owes. At the other end of the spectrum in Georgia, meanwhile, lawmakers held a hearing on a bill that would, and I'm quoting from a Georgia State News Service here, ban abortions in Georgia from the moment of fertilization and codify it as a felony homicide crime unless a pregnant woman was threatened with violence to have the procedure. Now, under this bill, both the woman and the doctor could be charged with murder. This bill is unlikely to be enacted this year, but I feel like the Overton window on this continues to move towards maybe punishing women with poor pregnancy outcomes.
Well, and punishing women who have trouble getting pregnant, as some of the opponents of this bill are arguing. It's not clear whether it would really be possible to do IVF procedures if, the bill was enacted how it was written. And even it seems like some of the reason why some pretty anti-abortion groups are concerned about this law because they feel uncomfortable that it's penalizing or going after the woman rather than other people involved in the abortion system.
I feel like we've been creeping this direction for a while, though. Obviously this bill's probably not going to move the cycle, but it got a hearing. I mean, we've seen a lot of things like this introduced. We've rarely seen it progress progress to the hearing stage, another thing that bears watching. So last week, in the segment that I'm now calling MAHA in the States, we talked about West Virginia banning food dyes and additives. Well, hold my beer, make that water, says Utah. Utah has now become the first state to ban fluoride in public water systems. Something takes effect next month. Lauren, I feel like states are like rushing to match RFK Jr. Is that what we're seeing?
There is some interest at the state level, but I also think it speaks to RFK's limitations. I think everybody always thinks the game is always in D.C., but there's a lot the states can do. And so I think it'll be fascinating to kind of see how this continues to play out.
Yeah, well, we will keep watching it. All right, that is this week's Health News. Now we will play my interview with KFF Health News' Julie Appleby. Then we will come back and do our extra credits. I am pleased to welcome back to the podcast KFF Health News' other Julie Appleby, who reported and wrote the latest KFF Health News Bill of the Month. Julie, welcome back.
Thanks for having me.
So this month's patient is yet another with a gigantic colonoscopy bill, but there's a twist with this one. Tell us who he is and, important for this story, what kind of health insurance he has.
Yes, absolutely. His name is Tim Menard, and he lives in Addison, Illinois. He bought his own health insurance after he left his management job to launch his own business. So he shopped around a little bit. This is the first time he's bought insurance, and he chose a short-term policy, which is good for 6 months in his state. And the first 6 months went pretty well, and he was still working on starting his business, so he signed up for another short-term policy with a different insurer, and this one cost about $500 a month.
So remind us again, what is short-term health insurance, and how is it different from most employer and Affordable Care Act coverage?
Right. These types of policies have been sold for years. They're generally intended for people who are like between jobs or maybe just getting out of school. They're a temporary bridge to more comprehensive insurance. And as such, they are not considered Affordable Care Act qualified plans. So they don't have to meet the rules that are set under the Affordable Care Act. So, for example, they might look like comprehensive major medical policies, but they all have sort of significant caveats. And some of these might surprise people who are accustomed to work-based or ACA plans. So, for example, like in Tim Menard's plan, some set specific dollar caps on certain types of medical care. And sometimes those are like per day or per visit or something like that. And they can be sometimes far below what it actually costs. And all of them, this is a key difference with ACA plans, all of these types of short-term plans screen applicants for health conditions, and they can reject people because of health problems or exclude those conditions from coverage. Many also do not cover drugs or maternity care. So people really have to read their policies carefully to see what they cover and what they don't cover.
So this is sort of like pre-ACA. It's cheap because it doesn't cover that much.
Exactly. That's why they can offer them lower premiums. Now, again, some people with a subsidized ACA plan, these are not necessarily cheaper, but for others, these are less expensive.
So back to our patient this month. He does what we always advise and calls his insurance company before he goes for this because it is obviously scheduled care, not an emergency. What did they tell him?
Well, I think he only asked where he could go. He was concerned that he would go to a facility that was in network, and they told him he could pretty much go anywhere. He did not ask about cost in that phone call.
Yeah, so he gets his colonoscopy. Everything turns out okay medically. And then, as we say, the bill comes. How big was it?
He was left owing $7,226 after his plan paid about $817 towards the bill. They got a little bit of a discount for being insured, but then he was still left owing more than $7,000.
And what was the explanation for him owing that much? Just a reminder that, this should have been fully covered if he'd had an ACA plan, right?
That's correct. Under the ACA, screening colonoscopies and other types of cancer screenings are covered without a copay for the patient. But he didn't have an ACA plan here. So what was the explanation? Well, this time he did email his insurance company, which is Companion Life Insurance of Columbia, South Carolina. And they wrote him back and they told him his policy classified the procedure and all of its costs, including the anesthesia, under his policy's outpatient surgery facility benefit. What is that, you might ask? Well, in his policy, that benefit caps insurance payments within that facility to a maximum of $1,000 per day. So the most they were going to pay towards this was $1,000 because they classified the whole thing as an outpatient procedure with that cap. And this surprised Winard because he thought the cancer screening was covered and he would only owe 20% of the bill, not almost the entire thing, basically.
So how did this eventually work out?
Well, we reached out and tried to reach Companion Life, and we also talked to Scott Wood, who works as a program manager and is a co-founder of a marketing company that markets Companion Life and other insurance plans. And he thought there was some room for interpretation in the billing and in the policy language. So he asked Companion Life to take another look. And shortly after that, Menard said he was contacted by his insurer, and a representative told him that upon reconsideration, the bill had been adjusted. And he wasn't really given a reason why that happened. But as it turns out, his new bill showed he owed only $770.
Which is, I assume, about what he expected when he went into this, right?
That's correct. He didn't think he was going to have to pay as much as it was initially billed at.
So what's the takeaway here other than to come to us if you have a bill that you can't deal with?
Right. Well, I think experts say to be very cautious and read the plans very carefully if you're shopping for a short-term plan, and realize they have some of these limits and they may not cover everything. They may not cover pre-existing conditions. And this could become more widespread in the coming years as short-term plans have been somewhat of a political football. So out of concern that people would choose them over more comprehensive coverage, President Barack Obama's administration limited them to terms of 3 months. Those rules were lifted during the first Trump administration, and he allowed the plans to again be sold as 364-day policies, just 1 day short of a year, and then you could try to get another one, or in some cases, the insurer could opt to renew them. And then Joe Biden came in, and President Biden called them junk insurance, and he restricted the policies to 4 months. So there's been bouncing back and forth, back and forth. Everybody really expects the Trump administration to do what it did like the last time and make them available for longer periods. So I think we're going to hear more about short-term plans. They may become more common. And again, it's just a matter of trying to understand what you're buying and why they might be less expensive in your mind than an ACA plan, but they might not turn out to be.
And you can always ask for an estimate, right?
And always ask for an estimate. That's a given. Experts always say before any kind of scheduled procedure, call your insurer, call the provider, ask for an estimate on how much this might cost you out of pocket.
Good. And if all else fails, then you can write to us.
There you go.
Julie Appleby, thank you very much.
Thanks for having me.
Okay, we're back now. It's time for our extra credit segment. That's where we each recognize a story we read this week we think you should read too. Don't worry if you miss it. We will put the links in our show notes on your phone or other mobile device. Rachel, why don't you go first this week?
All right. My extra credit is a piece in the Wall Street Journal, and the headline is FDA punts on major COVID-19 vaccine decision after ouster of top official by Liz Esley White. It's a great story. And I think we talked about earlier, I'm thinking about like what are the breaking points for companies, for industries as they look at how the HHS is changing. And I think one of those metrics is if the FDA starts missing deadlines to approve products. I think this one is a little bit of a special case because it is a COVID-19 vaccine, which is like the most highly politicized, medical product right now. But I think there could be other cases. And I think industry is watching this so closely to see if some of these changes at FDA really do bleed into approvals, whether the approval process will be politicized, whether they're going to start missing deadlines. And given just the amount of financial support that, industry provides to fund routine activities, I think this was kind of a really good marker in this process as we learn what the impacts are.
Yeah, I agree. Lauren.
I read Miscarriage and Motherhood by Ashley Parker, now at The Atlantic. And I got to be honest, if you read it, be in a place where you can cry. It's an incredibly moving piece about tragedies of miscarriage and, frankly, about women's health care and how little support and understanding there is in general about what surrounds that entire field. And some of the fascinating parts in it is when Ashley details going in for a D&C and being told, that is an abortion. And it's kind of an interesting interplay between what words mean, what people understand what words mean, and what exactly parenthood entails in modern America today.
And how extremely common miscarriage is. I think people just don't realize because it's something that's just not talked about very much. It's a really beautiful story. Sarah.
I looked at an MSNBC piece by Jahan Jones about Florida considering easing their child labor laws after pushing out immigrants. And the state is considering bills that would allow very young teenagers to work overnight, to maybe work in the kinds of jobs that would normally be seen as too unsafe for such young people. And it just seems like an interesting sort of consequence of pushing out immigrant workers, but also, it comes after some really moving reports over the past few years, too, about just how dangerous some of this work is and how even under current laws that is supposed to prevent this, particularly immigrants and the most vulnerable workers have ended up with young people in this job, and these types of jobs, and they've been harmed by it.
Who could have possibly seen this coming? Sorry. My extra credit this week is from Stat, and it's called Uber for Nursing is Here, and It's Not Good for Patients or Nurses by Katie J. Wells and Funda Ustek-Spilda. And it's yet another case of something that sounds really good, using an app to help nurses who want to find extra work and set their own schedules get it, and helping facilities that need extra help find workers. But like so many of these things, it's not as rosy as it appears unless you're the one that's collecting the fees from the app. Workers are basically all temps. They may not be familiar with the facilities they've been assigned to, much less the patients, which doesn't always result in optimal care. And they bid against each other for who will do the job for the lowest rate, creating a race to the bottom for wages. It's another one of those quote-unquote advances that's a lot less than meets the eye. All right, that is this week's show. As always, if you enjoy the podcast, you can subscribe wherever you get your podcast. We'd appreciate it if you left us a review. That helps other people find us, too. Special thanks, as always, to our producer, Francis Ying, and our editor, Emery Hudeman. As always, you can email us your comments or questions or at whatthehealth, all one word, at kff.org, or you can still find me at X at J. Rovner and at Blue Sky at Julie Rovner. Where are you guys these days? Rachel, you're still on LinkedIn, right?
Still on LinkedIn, still on X. I do have Blue Sky account, too, but any and all the places.
Excellent. Sarah?
Yeah, I'm Blue Sky, some X, some LinkedIn at Sarah Carlin or at Sarah Carlin Smith.
Lauren?
I'm still on X, and I am on Blue Sky at Lauren Weber HP. And as a member of a congressional staffer asked me, does the HP really stand for health policy? And yes, it does. So still there.
Absolutely. We will be back in your feed next week. Until then, be healthy.